All right, so I volunteered last year to give the basic talk so that when the real researchers like Dr. Hopkin and Dr. Scott are up here, they don't have to do the basics and they can talk about their actual work. So if you listen to this whole talk and you know all of this,
Is anyone belong to this little munchkin? Right here. Thank you.
if you hear this talk and you know all of this, fantastic. So that means you've either been to a conference before or you've done a lot of digging on the internet. If it's your first conference or you have someone with a new diagnosis, then hopefully I can cover the basics and you'll probably hear some of these things again. Takes a little while to sink in if you don't have a science background, but hopefully you'll learn a few things that you can take with you. So we call this, what is it, what do I need to know, and what do I do now? Do I need to point it? All right, how do I advance my slides? Yeah. Thank you, Cindy. All right, so disclaimers first. So I'm employed by the federal government, so surprise, I have to give you a disclaimer. So I work for the U.S. Food and Drug Administration. The opinions here are mine and mine alone, and not those of the FDA, nor the U.S. government. I don't know why I have to tell you that, because it's not like I'm going to talk about some way to fix this or treat it or anything that has anything to do with my job, but they make me say it. Second of all, this is a presentation of facts and findings. It's not a substitute for having a relationship with your doctor and having discussions about whatever your kid needs and what is unique to your child's situation. And finally, in terms of conflict of interest, I have no financial conflicts of interest, but I do have a daughter with 1P36, so I think that comes with certain biases. So obviously, I feel passionate about this issue. All right, so what are our objectives? Well, to get some basic information about 1P36, about what their medical needs are, maybe to give you some ideas about how to help your 1P36er, and talk about realism, but realism with hope. You know, I'm going to try to present the stark medical facts, the numbers, the percentages, and that sort of thing. But I think if you look around this room and you listen to Callie's talk, you know that there is a wide spectrum here of how our kids do. Some of them are quite severely affected, and some of them not so much. And Callie's pretty amazing, and Todd must hate me that I have to talk after her. But you see there's this wide spectrum here. So keep that in mind as we go through these numbers. I think sometimes it seems like a rather grim picture. I think it's not so grim, but I think we should all kind of just see what our kids are like, see what the other kids are like, particularly if you've never met another 1P36er. Until yesterday, I guess. So if your child was recently diagnosed, I think this is pretty overwhelming. I think your first conference is overwhelming, because maybe you've never even seen another kid with 1P36, and all of a sudden you're in the room with 50 people, and we all have things going on in all three rings at the same time. So I think it's a lot of stim, and it's emotionally a bit overwhelming. And I guess, look, everybody in this room has been through this, and you know, maybe not exactly your situation, but certainly something awfully similar. I got my daughter's diagnosis while in the car over the phone while driving to Home Depot, which is not the usual way you would do it. I knew our geneticist, and the story was they had lost Wendy's test results, and she was just going in to have them drawn again. Oh, and they happened to find them. So literally, I got called on the cell phone while, you know, just running errands. So I think we all have a story of things that haven't gone perhaps as smoothly as they could have. But everybody in this room has been through something that is certainly dramatic and traumatic. So, hey, you have a lot of shoulders to cry on when you need it, and a lot of people to ask questions of and to share ideas. There we go. It's a little dark. Throughout this, I just put in pictures of past conferences, and I think what you should take away from this is people smiling and having a good time. We've all had some really difficult stuff, yet we always manage to somehow bond together and smile and enjoy ourselves, despite maybe challenges that most people don't face. So, chromosome basics. We all have 46 of these things. And number one is that one in the upper left-hand corner. Cindy, if you want to advance that one. Seen there. And so named, I think, just because it happened to be the biggest one. But the fact of the matter is, our kids have the same thing, and if you looked at just this picture, unless you're very, very good, you can't tell whether that person has the end of 1P missing or not. P is just the short arm of chromosome 1. You can go to the next one. So here's chromosome 1, and if you blow it up, they have these things called bands. You stain them and look under the microscope, and if Cindy will hit the next one, that's 1P. That's the very end. It's not very big in terms of all the DNA that all of us have. It's a tiny, tiny piece, but it's a very, very important piece. It's not like something as dramatic when you look at it as, say, someone with Down syndrome. They have a whole extra chromosome. It's just a tiny little piece missing. And some of our DNA is important, and some isn't. 1P just happens to be full of things that are really important. And it can be different sizes in different people. Not every kid has the same deletion, and they can vary in size quite a bit. But the problem is, well, as of yet, and Dr. Scott will talk a lot about this, we can't exactly correlate the missing piece with exactly what your child is going to look like. And most people have what's called a terminal deletion, or a deletion at the end of the chromosome, at the very tip, but it doesn't have to include the very tip. The tip can be there, and you can be missing a part just before the tip of it. That's called an interstitial deletion. I don't know that that matters a lot for the sake of this, but just know that if you looked at every kid in this room and you looked at their chromosomes, you might have 50 different deletions, or maybe you'll have 30 different deletions. There'll be one or two other kids with the same as your kid, but all of our kids are sort of different. Unfortunately, again, we can't exactly predict what that means. So more pictures, and you might recognize friends from previous conferences or other kids. I think these pictures are from the Tennessee conference. Quick stuff. Does it have another name? No, it's not named Wendy syndrome or whatever. It's 1p36 deletion. It's sometimes called monosomy 1p36, which simply means you have one copy of that region instead of the usual 2 copies of all regions. But in medical speak, that's exactly the same thing. So how common is it? We think it's about 1 in 5,000 to 10,000 live births. So as far as genetic things go, that's actually pretty common. But obviously, it wouldn't be as common as heart disease or breast cancer, one of those things, right? But as far as genetic things go, 1 in 10,000 is not rare. So there are a lot of people in the US with 1p36 deletion. Many of them may not be diagnosed because the technology, if you listen to Callie's story or any of the adult 1p36ers, the technology wasn't good enough to pick this up, or you needed a very good geneticist to pick it up. I'm sure there are people out there in their 40s and 50s who don't have a diagnosis, who look just like our children do, and may never get a diagnosis simply because, I don't know that that's terribly important, except for, and we'll talk about this in a little bit, their family. But in reality, there's probably a few thousand people in the US. There's about 2 to 1 females to male, girls to boys. And I think if you look around the room, you'll see that. There's a lot more girls than boys. I don't have a good explanation for that. I don't know if anyone does. But that seems to be certainly a true observation, both in what is written about 1p36 and what I see at the conferences. And keep in mind that my expertise is more as a dad who happens to have gone to medical school than someone who has seen 1p36 patients or done research. So, I'll defer some of this technical stuff to Dr. Hopkin and Dr. Scott, but, I can read everything that's out there, and to me, that observation seems to be true. Can it be fixed? No. You just can't put a missing piece of DNA back in every cell in someone's body. It sounds like it'd be cool to do, but medicine is not that good. And I don't think that we will achieve that in any of our lifetimes. I could be wrong, but that seems to me to be so medically complicated as to be beyond the realm of what I can imagine we can do. I don't think that means we can't do anything to help our kids. I think there are a tremendous amount of things we can do to help our kids, but I don't think we're going to be looking at fixing this in our lifetimes. Is this your fault? No. There is nothing that you did or didn't do that made this happen. So for most people, both parents have perfectly normal chromosomes, and this is just some sort of random thing that happened, and unfortunately, one of our kids didn't get all of chromosome 1. For about 5 to 10% of people, they may have what's called a balanced translocation. So if you look at the picture, there's a bluish chromosome and a reddish chromosome. And they've gotten parts mixed up so that part of the blue is on the red and part of the red is on the blue. You still have 2 copies of everything. And if that's true, you're just fine. The problem is, if you pass one of those chromosomes on to one of your children that has both red and blue, they're going to end up with not enough of one and too much of the other. And that's where a problem can come in. So we think for about 5 to 10% of kids that have 1p36, one of their parents is carrying one of these balanced translocations. So you can go to the next slide. So what does that mean? It means if you have one of those balanced translocations and you're planning on having additional children, you may be at risk for having another kid with a chromosome abnormality or 1p36. So if you haven't had your chromosomes checked, I think it's particularly important if you're considering having additional children and you have a 1p kid, or you're the sibling of a 1p kid and thinking about having children in the future, and your parents haven't had their chromosomes checked. If your parents have normal chromosomes, I think you're in the clear. But in those 2 instances, I think having your chromosomes checked is probably really important. And it's something we all need to think about going forward because, many people in this room have adult children with 1p36. Some of those people have siblings. So if they're thinking about having children, probably they should have their chromosomes checked and know what their situation is. So you can go to the next one. Oh, sorry, back one. Sorry. We went twice. So children with 1p36 have many, many issues in common. I'm sure you can look around the room, right? They all kind of look alike. So they use similar facial features. They all have some degree of intellectual disability. And I think pretty much all of them have low muscle tone. Something you can overcome, but it's certainly an issue. Not every kid has every feature, right? Some have seizures, some don't. Again, at present, we can't really look at an infant and say, this person is going to have this problem and not that problem. I think we will get there, and that's a lot of probably what Dr. Scott will talk about. I don't think we're there quite yet. We're learning a lot about that, but that's really an area that's evolving. So more fun from previous conferences. At least one of these is from San Antonio. So common features, and I hope you can see Wendy's picture here. I used her picture because that way I don't have to ask permission from anybody. And you can kind of see they have these straight eyebrows, which I think is really sort of a very distinctive feature. They have these deep set eyes, a relatively flat bridge of the nose, and a small pointed chin. And while you won't find it described in any of the literature, they all have lots and lots of bushy hair. So I don't know genetically how you quantify that, but there is definitely something I think about our kids' hair where it grows fast and they have lots of it. We have to have Wendy's haircut like all the time. It seems to grow overnight. So intellectual disability. I think it would be fair to say that all children have some degree of disability, and you can look around the room and see the great variation. So we have Callie come up here who gives her 10-minute speech, and probably better than any stump speech I've heard from any candidate running for higher office. And were she of 35 years of age, I would gladly vote for her. Probably enough political commentary. But I would just say this. The severity of the disability cannot be predicted. Therefore, I think the reasonable thing, as Callie pointed out in her talk, the reasonable thing is to assume that your child is watching and learning everything you do from birth onward, and to get them as much help and therapy and stimulation as you can, because in any case, that's going to help your child develop to whatever their maximum potential is. And again, we can't predict what that potential is, so probably you should assume that your child is the next Callie Hoots and push them to be that so that they can be whatever it is they can be. And I think that falls under the category of, look, all of them are going to require some assistance or special education services. The more you can advocate for your child and the earlier you can do that, the better off you are. When I went to my first conference, we didn't even bring my typical daughter because I wasn't sure if it was going to be a very positive experience or not. The medical literature paints a fairly grim picture of 1P36. And my first experience was a kid walking onto the elevator who obviously looked just like my daughter. And you know what the biggest article on 1P36 says is the best vocabulary these kids will develop is maybe 2-word sentences. I think Callie proves that wrong. But this kid walks on the elevator, first day I've ever met another 1P36er in my life, and she says, "Hi, my name is Olivia. Is that your daughter? What's her name?" And I think in that one moment, I very quickly learned that maybe the medical literature wasn't a complete picture of this syndrome. I think since then a lot has been published. But I think we sort of all had this experience of people tell you very grim things. Certainly this is a challenge, but it's certainly not as grim as some people would portray. But I think it is fair to say that, look, all 1P36ers as adults are going to require some kind of assistance and are unlikely to be able to live completely independently. While I don't want to smash anybody's hopes, and I think it would be great if somebody achieves that at some point, I think you have to think about that, because quite honestly, I'm not getting any younger, and neither of any of us. So thinking about the future and future planning and who is going to take care of our kids is a really important thing to think about long term. And again, having them live independently would be a great goal. It's not something that I know of any 1P36er has quite achieved that. So I think fostering independence is great, but we all need to support them through that and think about that realistically. So just to go through some of the typical signs and symptoms that kids have, nearly everybody has low muscle tone or hypotonia. Affects about 95% of kids. I think the most obvious thing in infancy is it makes feeding difficult. They often have swallowing difficulties. It's difficult for them to suck. Sometimes it's difficult for them to close their mouth and swallow appropriately. And certainly it also interferes with physical development as they progress through the first year or two with things like crawling and walking. Strength is what your muscles are like when they're exerting maximum force. Tone is what your muscles are like when they are at rest. And our kids tend to be quite floppy. You can overcome that with strength. You can overcome that with physical therapy, but at rest, they're still pretty floppy. And so that's a challenge for them in eating in infancy and in developing physical skills. So again, things like PT and OT, physical therapy and occupational therapy are really important. And again, I would just say earlier is better and more is better because it's going to help them work through some of those issues. So heart defects, meaning physical defects, meaning the heart is not built the way it should be built. Present in about 50 to 75%. Holes in the heart or an atrial septal defect or ventricular septal defect, ASD and VSD are probably the most common, but there's a whole bunch of different ones described. They may or may not require surgery, but I think it's still important to know about that. And whenever I give you guys recommendations, I will say I've taken this completely from an article in something called Gene Reviews by Battaglia. I made a one-page handout, and Todd will either print it or post it on the website so you guys can get all of this list of recommendations. I'm not saying it's a complete list or a perfect list, but it's a reasonable working list to start from. So their recommendation is get an echocardiogram to evaluate for structural heart defects. And if there's problems, follow up by a cardiologist. We'll talk about something called cardiomyopathy, which is a problem with the heart as a pump, a little bit later. But in infancy, really what you're looking for is the heart built the way it should be built? So seizures, certainly a difficult challenge for many, many families. So present roughly half the kids. Onset is often between birth and 2, but there's been at least one person described who had their first seizure at 15. So I'd like to be able to say to you, if you make it to your second birthday, it's not going to happen. But I think really more appropriately, we would say if you make it to your second birthday and you haven't had seizures, it's unlikely to happen, but it could. So again, EEG in infancy, or in those with a first-time seizure, that helps the neurology people know what does this look like, what do they think they're dealing with, and perhaps how to treat it. But keep in mind that about 1/3 of the kids with seizures have very difficult to control seizures. Compared to maybe 20 years ago, we have a ton more options for treating seizures. Even with those quote new drugs, some kids still, we can't control their seizures. More drugs are in development, there are kids in clinical trials, but this is still a challenge for a lot of our kids. And I would say, look, a seizure is not something that's terrible for your brain, but prolonged seizures or frequent seizures are clearly not good for your development. So seizure control is an important component of sort of doing everything you can to help with your kid's development. I wish we had better medicines, but this is one of those things that I think over the next whatever decade will evolve as we learn more about 1p36 and we have new seizure drugs. I think we will get better at this. But for right now, about 1/3 of the kids with seizures, we're unable to control them and prevent them from having seizures. So hearing and vision issues are pretty common, and these aren't something that are easy to measure just looking at your child. There are plenty of kids that, you know, as a pediatrician, you would not know they have hearing issues until they're 2 or 3 and their speech development lags behind. So we know it's quite common in our kids. So again, maybe about 50% with hearing loss. So we can pick that up by doing testing, and hearing aids can clearly help that. That's certainly important for maximizing their speech development, which is very much an area of challenge for our kids. And again, maybe 1/3 to half with vision problems. So again, many of those things can be corrected with glasses or medication. If you look around, you see a number of our kids all wearing the same brand of glasses because they're virtually indestructible. And our kids are hard on those kinds of things, if they'll even keep them on. But again, an eye exam is important. Make sure, because if you're gonna learn to walk, probably having an idea of where your feet are and what's in front of you is quite important. And if you can't see that clearly, that's just another disadvantage. So cardiomyopathy, I mentioned it earlier, the problem with the heart as a pump. Again, it occurs in maybe about 1/3 or a little less. It can occur in infancy or adulthood. And to stress, you probably wouldn't know this as being a parent unless it was quite severe. Your heart can be functioning at a less than perfect way, and you'll still be walking around and doing the things you normally do. From what I've read and what I know, early treatment is better treatment. So picking this up before they are showing symptoms and problems is reasonable. There's an article by a woman named Ashley Brazil who worked with Dr. Hopkin, who we'll talk later. And what she said in her article is that probably a cardiology evaluation in infancy and then an echocardiogram every 2 to 3 years is a reasonable place to start. I think these recommendations, as we learn more, as there are more research and more publications, we'll have better recommendations. But I think for the moment, that's probably where we are. And as we get more studies, we'll understand how often should we have our kids screened, or how often do they need an echocardiogram. But this is something important that we need to pay attention to because it is not a common pediatric problem and not something that maybe every parent or every pediatrician would think about unless they've really done their homework about 1p36. So skeletal defects, meaning defects of the bone. And it can be something that's trivial, like having an extra rib or missing a rib. And honestly, without an x-ray, you know, I could have 11 ribs instead of 12 and I would never know. So some of those are unimportant. Scoliosis, which is curvature of the spine, can be quite important. If it's severe, it can actually interfere with breathing and require surgery. And scoliosis surgery is not a trivial thing. It's a really big, major surgery. So I'd say, in particular, thinking about bone issues, monitoring for that is important. But just know that many of these kids, if you really did x-ray them and look carefully, they might have minor bone defects. It's probably not of any importance to their daily life, but scoliosis is the one I can think of that can be important. So watching for curvature of the spine is an important screening thing to do, which most every pediatrician should be doing every time they see a patient anyway. So you got, yeah. So genitourinary abnormalities. So abnormalities of the urinary system or the genitals. Found in about a quarter of kids. And these include things like kidney defects or defects of the external genitalia. Kidney defects are important because many of them will make you prone to frequent urinary tract infections. Frequent UTIs can lead to kidney damage. So if they have concerns, then obviously that's something important to follow over time. And I keep saying that, and I apologize, but our kids have a lot of these medical issues that you kind of need to stay on top of and follow over time. And that consumes a lot of time and mental energy. And I think that's one of the sources of our stress, without a doubt. Reasonable recommendation, have a renal ultrasound in infancy, measure labs to look at kidney function, and probably once in infancy, and then as needed if your child is that unfortunate one that seems to be having frequent urinary tract infections. So behavior issues. Wow, there's not a lot out there in the published literature about our kids and behavior issues. But if you talk to people in this room, I think you will quickly find that it is a very, very common thing that we struggle with. So maybe present in a third to half. And I would say that it is maybe an understatement and maybe it's obvious, but this can be very severe and impair the quality of life for not only the one P36er, but also the entire family. And it can make just leaving your home very difficult. And it can include things like biting of the hands and wrists. You'll see a lot of our kids wearing wrist guards because they like to bite on their hands. Tantrums are what are called stereotypies, which are simply repeated purposeless movements, things like head banging or hand flapping. And I would say that a lot of our kids have sort of this obsessive eating tendency that's not in the literature, which is why I generally put a question mark behind something if it's just my observation or opinion. But I think if you let my kid have free run of the refrigerator, she would eat until there was nothing left in the refrigerator. Particularly if it was full of like slices of cheese, or if you let her have Pepperidge Farm goldfish, she would eat the entire shelf of the grocery store. And whether that's truly an issue with eating, or whether that's more an issue with obsessive behavior that focuses on eating, I don't really know. But I mean, just talking to other parents, I think you see that they have a tendency toward these sort of very focused, obsessive, repeated behaviors. I've gone through every child-proofing item that you could name to close our kitchen cabinets so that my daughter cannot bang them all day, every day. Magnetic locks finally worked. Now, I can't get into my cabinets either, but she can't bang them and make noise. But that's still a good compromise. And just to say, I think, you know, my daughter has done behavior therapy, and, you know, it is intensive. My wife takes her, you know, an hour to downtown Baltimore twice a week for 2-hour appointments. They even do inpatient for some kids, but it is very time consuming. It can take months, and it can be expensive. So again, this is not an easy issue to deal with, and many of us have gone through this. I wish there was a simple answer, but I think when you get to this point where you need help, you kind of know, and then you try to find someone or a group in your area who can help you. What they've done for Wendy is not particularly sophisticated, but it works, but it's taken a couple of months just to start to see progress. So it's been a big investment of time. But this is certainly common for our kids. So speech, I think expressive communication, so talking essentially, or communicating in other ways, is the hardest thing for our kids. Many of them have quite good understanding or receptive language when you talk to them, but for them to talk and communicate back is more difficult. And looking again at Ashley Brazil's article, which looked at only kids who are 12 years of age and older, about 50% were nonverbal, but more than half of that other group, so 31% of the total, used more than 100 words. So again, maybe the take-home message here is there's a huge spectrum where some kids don't communicate well at all and other kids communicate in very sophisticated ways. I think what I have learned is that you don't need words to communicate effectively. And when Wendy can't get her point across, she will just take me by the hand and drag me to where I need to be. And then she bangs on her pantry door and I open it. And then she puts her arms up in the air and I pick her up. And then she grabs a cup of macaroni and cheese and hands it to me. I know what that means. That means I want mac and cheese. But she's done that without actually using any real signs. She also uses an iPad. But you can get your point across quite well without using words. Alternative communication methods, and some of us have had great success with that, are also quite handy. There are iPad apps that you can buy for less than $100 that you can completely personalize and modify to your particular needs and are very, very easy to use. And some of our kids are absolutely a whiz with an iPad. Wendy knows how to go from app to app at this point and find whatever she needs, which is mostly the cat in the hat or her program to talk. But these are good things to try. And I think if you just ask other people in the room, if you're at that stage, be happy to show you our iPads or tell you what we use or how it works. But bottom line, speech therapy or help with other forms of communication are really essential to helping these kids be as independent and effectively communicate as they can. So development, and just to say it varies widely. So there's no accepted normal range. I don't think you can say, 1P36 kids walk at age 3. There just isn't that kind of number. It would be convenient and nice. We don't have it. And again, there's no good way of knowing what is my child's development going to be like when they're 6 months old. But again, I would just stress getting involved in therapy and having skills, activities designed to help them practice their skills is really important. You don't have to be a therapist to do therapy, right? Anything that uses your hands is going to improve fine motor coordination. Anything that makes you bear weight on your feet is going to help with walking and developing muscle strength. So if you just think about the picnic yesterday, you see kids out there pushing around in their reverse walkers. They're building strength and learning balance just by doing that, particularly when they're going across uneven surfaces. They're learning all about how do I balance and feel my feet and know what it is that I need to do and adjust all the time to keep my balance. So just giving kids a good variety of those kinds of exposures and experiences is in and of itself a kind of therapy. So everybody wants some normal. So I pulled what I could out of what's published out there. And most of this, again, comes from Ashley Brazil's study. So about 80% walked in one study, and the range was about 6 months to 8 years. So, if your kid's not walking at 3, I wouldn't despair. Just keep working on it. Again, about 44% use words, with first words developing like 9 months to 12 years. And I've certainly heard people say even later than that. So again, if your child's nonverbal and they're 8, I would just keep working at it. And 52% achieved some degree of toilet training between 2 and 12 years. Toilet training is clearly difficult. I think we've been working with Wendy for a couple of years. And, like everything else, it comes and goes. Sometimes she's really into it. Sometimes not into it at all. I would say that she's completely capable of being toilet trained if she cared about that. But it's hard sometimes to motivate a kid or make them care. But it is a slow process. Almost like any new skill with their kids, it takes some time to work at it. So just more happy conference pictures. And so medical care, and just a few more questions. Will your doctor have heard of this? Probably not, especially if they're over 40. When I got the diagnosis, one of my first questions was, is this going to be in my genetics textbook? And the geneticist said, what color's the cover? And I said, dark green. She's like, no, it's not, for 2 more editions after that one. Now, if you have a computer and internet access, obviously, then you can look this up. So can your doctor. But is it something that most people are going to know about? No. But again, there are easily available resources. The 1P36 DSA webpage has the largest article looking at kids and describing the syndrome, kind of the basic article you might want to just pull up and read. It's there. The handout that I snipped out that'll be on the webpage or Todd will print out is from somebody called Battaglia who also wrote that article. from Gene Reviews. There's the URL. And I have some other references at the end of the presentation. And hopefully we'll make this presentation available on the website. Or you can just take a picture with your phone. But the resources are out there. Maybe the easiest way to help your doctor is to print that copy out and hand it to them. I know that sounds simplistic and primitive in this day and age, but if they have to look it up, there's no guarantee they will. If you put it in their hand, chances are they'll put it on their desk and they will have to look at it because they'll probably feel guilty throwing it out. So putting it in their hand is not a bad idea. So you need a really good doctor. I don't think exactly what their specialty is matters. Okay, geneticists are used to managing kids with all of these different multiple issues we've talked about. So certainly geneticists are used to doing this and are good at this. Can a really good pediatrician who's willing to invest the time do this? Absolutely. They are qualified and know what to do, but it requires a lot of time, a lot of patience, and a lot of work. So again, to me, more important than what their specialty is that they're willing to do that work for you and put you in touch with the right people. If you have a good relationship with your pediatrician and they're working hard for you, that's terrific. But again, geneticists are probably more used to doing this. So here's just kind of a list of things that we've sort of touched on as we've gone through here. So monitoring growth and development, every pediatrician does that for every kid at every well visit. Cardiology, EEG to look for seizures. Thyroid test, I didn't mention it, but maybe 10 or 20% of our kids are hypothyroid, so they do need thyroid tests. Certainly everybody has one of those as part of your newborn screen. And so some of that may be covered. It doesn't always pick up everything. Genetics consultation is certainly worth it. Hearing and vision evaluations, feeding and swallowing evaluations, certainly a challenge. You hear a lot of our kids coughing and choking sometimes when they eat. You know a lot of our kids have G-tubes. And again, when they have G-tubes, a lot of times that's because they don't swallow well and we're trying to protect their lungs. Education evaluation and school placement when they get to be school age. Certainly almost all of our kids are going to need some assistance, whatever that might be. And I guess anything else that your doctor sees or is concerned about, have checked out. So I think our kids are the ones that, you know, most kids, you see them, you see something a little funny and you say, we'll come back in 6 months, we'll take another look at it, see if it's changed. That's probably not our kids. We need to be more proactive simply because they have many medical issues and probably picking them up earlier is better. So obvious things you can do. Therapy, and I know I've said it like 6 times already, so I'll say it again. Earlier is better, more is better. Whatever services you can access, do so. It's really, really valuable. If we didn't have a good PT, Wendy would not walk or run. And many of you have seen how much we have to chase her. So physical therapy has been incredibly effective. All states, you know, by federal law passed like in the 70s, have to provide services to kids less than 3 years old who have developmental issues. So if you have a diagnosis and you are sitting in this room, you are eligible for those services if your children are under 3. It might be called something different. It might be called infants and toddlers or, you know, early educational services. It has different names in different states, but it's there and it's available to you. As Callie said, be an advocate both for their medical care and their education. And another thing you can do is keep really good records of all the medical visits and all the issues and all the tests to give your doctor a complete picture. The medical system is incredibly patient unfriendly, and it's also very fragmented. It's very, very difficult, for reasons which I still don't understand really, for one doctor to communicate to another. When you see the cardiologist to get results back to your pediatrician, the system just does not work terribly well. With electronic medical records and such, we're getting better, but it's still not great. The more copies of everything you can get and compile in one place, so if it doesn't get to your doctor, is a really smart and efficient thing to do because that information is not always going to make it back to your regular doctor. So keeping a record of everything can be very, very helpful. Sometimes you have to be a bit annoying to get those test results. Be polite, smile, but be very persistent. So productive doctor visits. Write a list of questions. Hit the important ones first. Don't leave them to the end. We all like to talk a lot. So if you ask us the sort of more trivial questions first, we're going to spend all the time on that stuff. So try to hit the big important ones that you're concerned about first. you're going to need more time than the average kid when you see a pediatrician. You know, when I was in practice, we did 15-minute visits for most things. We usually schedule an hour for Wendy just because there's a lot to talk about. So make sure if you're new to an office that you explain the situation and schedule enough time. And the more organized you can be, the more helpful it will be to the staff and to the physician to get your kid good care. So just things like keeping track of height, weight, and insurance info, contact information for all specialists, date of last visit, what was discussed, list of tests and results, medications and dosages, and a problem list, which simply means all the issues that are going on that we're keeping track of. That can be really, really helpful. That list sounds like nothing, but it's a tremendous amount of work. But if you can do it, your kid will get better care, because then you have at least your doctor and you making sure nothing falls through the cracks. And anytime you can have more than one person keeping track of things, you won't miss things. Just more conference fun. So our study's being done. Yes. As many as we would like? No. But here's a list. All I did is I did a search on the public medical database of articles for 1P36. I read the titles and decided, were they really about 1P36 or something else? And I came up with about, I think, 53 or 55 articles on 1P36. If you look since 1999, you can kind of picture that the number is growing. I would say that in terms of 1P36 research, we're sort of in toddlerhood. We know the basics about the infant. We have the ideas of, what kind of problems do they have, how often. We may not know exactly how that evolves over time. We may not know a whole lot about exactly what the behavior issues are, but we know they have behavior issues. We're learning more all the time, but research is a slow process, because obviously even if it's 1 in 10,000, it's hard to put a lot of people with a certain syndrome in one room together, except it's something like this. So how can we promote research? 1, participate in studies. You can't learn stuff if you don't have patients. So this is a really important gathering for people to be able to get all of us in one room and learn stuff. Promote awareness. And if that's fundraising or if that's just wearing your t-shirts and getting the name out there, it's all good stuff. But research is a very expensive proposition. It is incredibly costly. So how can we promote that? Well, my commercial message. If you are wealthy, famous, or politically influential, please see Ken. Really, many diseases which may be quite obscure get research funding because there is a congressperson whose grandkid has it, okay? I wish it didn't work that way, but it does. So if you have some influence, by all means, we would welcome your help. Because funding means research, research means learning stuff. But honestly, it is sadly financially driven. So resources for you, of course, the DSA page, the Facebook group. People ask questions and share stories and say, have you had this problem and what did they do all the time there? And again, there's the URL for the list of issues requiring follow-up. So I want to end with something very practical and just sort of funny of 6 things I've learned from Wendy. Laugh, even if you don't know what's funny. Because, we have enough tears in our lives. Success has nothing to do with getting into Princeton. I was just so excited and overwhelmed the first time she drank from a straw. It was at some obscure Mexican restaurant on our way home from our first conference, right? That's not a milestone that most parents remember, the day they drank from the straw for the first time. But yeah, you got to celebrate those little successes. Any day your child is not in the hospital is a good day. Developmental delay does not mean you are innocent. Do not underestimate the ability of your 1P36er to be devious or to behave badly intentionally. They are children, even if they don't have the end of the first chromosome. They are fully capable of bad behavior. I understand more than you think I do. I will do things you never thought I would do. I am always watching and listening. don't give up on me. And finally, sometimes your child is going to drink from the dog bowl. Pick her up, wipe her off, move on. I will be here for the conference. I am happy to answer questions at any time, whether it's here or at the pool or wherever, or at 1 a.m. when people are enjoying a coffee in the lobby, or whatever. So if you have questions, by all means, grab me. Thank you.